Good morning. Thank you. Please be seated. We'll go back on the record in the matter of State of Utah versus Martin Joseph MacNeill. Mr. MacNeill is present with his counsel. The state's attorneys are present, and the jury is seated. The state may call its next witness.
The state calls Dr. Gary Dawson.
Dr. Dawson, if you'll come forward here to the clerk's desk, please raise your right hand and be sworn.
You do solemnly swear the testimony you shall give in the case now pending before the court will be the truth, the whole truth, and nothing but the truth, so help you God.
I do.
Thank you. If you'll be seated on the witness stand and respond to counsel's questions. Do you have a cup there?
Yeah, we
Got him. Okay.
Morning, Dr. Dawson. How are you?
Good morning. Thank you.
Thanks for being here. Will you state your name and spell it for the record, please?
Name is Gary Dawson, spelled D-A-W-S-O-N.
Thank you. Will you tell us what your occupation is?
I'm self-employed as a pharmacologist, toxicologist, and a clinical pharmacist.
Okay. Will you tell us briefly what pharmacology is?
Pharmacology is the study of the effect of drugs on the human body.
Okay. What type of education have you received in order to work in this profession?
I have a bachelor's degree in pharmacy, a master's in pharmacology, and a PhD in pharmacology, as well as several hundred, if not thousands, of hours of continuing and ongoing training and education.
Okay. Will you describe your PhD work?
My PhD work was focused on drug metabolism, and specifically the absorption, distribution, metabolism, and excretion of amphetamine and amphetamine-related analogs in both animals and humans.
Okay. When did you receive your PhD?
In 1976.
And when you talk about the study of metabolism, will you just give us a brief definition of what you mean by metabolism?
Metabolism is, when we think about that, is in terms of in the big picture of how drugs are taken into the body, in other words, absorbed, how the body distributes them around the body through the blood and the various tissues, how they're metabolized, and how they're excreted. And so it's each one of those steps has a specific or sort of unique effect upon how drugs are handled in the body.
And when did you receive your PhD? I'm sorry,
76.
And what institution were you studying at?
I was at the University of Alberta in Edmonton.
Okay. Do you have any specialized training?
Additional training, considerable additional training, particularly as it relates to the study of new drug development in humans. Approximately 10 years of specifically related to the pharmaceutical industry, and how we go about developing new drugs, how we use them in humans for the first time, how we do the ultimate development and the subsequent understanding of how drugs apply to the general population. In addition to that, I can't even count the number of hours of additional training in terms of specializing the effects of how drugs affect the central nervous system, how they affect the body, particularly as it relates to CNS depressants and drugs that affect performance and behavior, and include everything from alcohol to drugs that are used such as antipsychotics, or drugs that are used to modify behavior.
Thank you. Are there any licenses that are particular to your profession?
Well, there's the licensing piece would be as it relates to pharmacy. I'm licensed to practice pharmacy in 4 states. But there's also additional sort of recognitions, if you will, from professional societies.
Okay, let's, will you just briefly describe what it means to be licensed to practice pharmacy?
Well, to be licensed to practice the profession of pharmacy, you have to be recognized by the State Board of Pharmacy in a particular state as having, number one, met a predetermined level of education. Then you have to pass examinations that show that you are competent in terms of the practice and art and science of pharmacy, but also in terms of the legal ramifications of the art of the practice of pharmacy in that particular state. And each state has a little different take on the legal requirement. The competency piece is fairly standard. But you do have to do it by examination, and certain parts of it can be done by reciprocity, but the legal piece has to be done by examination to the other states.
Okay, and so when you talk about examination, you're talking about taking a test to show that you know what you need to know in order to practice.
Yes.
Talking about reciprocity, will you define that?
Well, the reciprocity piece is once I've established my my certification, my registration, my licensure in a state, say for instance Idaho as my primary state, other states recognize that licensure because I'm a graduate of an accredited college of pharmacy and I've passed a National Association of Boards of Pharmacy kind of minimum standard, and that piece then is accepted by the other states. And so if I want to practice pharmacy I'm licensed in Colorado, for example. If I want to practice in Colorado, they give me credit for my licensure in Idaho, but I have to pass their law exam.
Okay. So if it's good enough for Idaho, it's good enough for Colorado. That's
right.
Kind of the basic idea. You've mentioned you worked for about 10 years in new drug development. Will you describe other professional experience you've had?
For approximately the first 10 years of my career, I taught and conducted research in an academic medical center setting and was part of a training team for medical students, medical residents, pharmacy students, where my responsibility was to work closely with the attending physicians in training those individuals in the effects of drugs on the human body. And what we would do we're teaching, there's a piece of it was teaching the medical piece, there was a piece that was teaching the pharmacology piece. And so we would be working directly with and providing direct patient care to patients in the hospital in conjunction with the attending physicians, but also working with the medical students and the medical residents, teaching them the finer points, if you will, about how drugs are selected, how they affect the body, what the adverse effects can be, and building upon their knowledge of the medical piece with the pharmacology, toxicology, pharmacy piece. That was about the first 10 years. The next 10 years, I was involved, I had my own company in doing home health care services. And one of the things that we spent a great deal of time in was working with inpatient and outpatient drug and alcohol rehabilitation. And so we're providing a lot of direct patient care, not only in the sense of working directly with inpatients, but with outpatients as well, and visiting with them and evaluating their drug therapy, how they were responding to drug therapy, or if there were any complications. And it was at this time where we developed, in conjunction with some of the physicians I worked with, one of the earliest collaborative treatment programs where the physician would turn over many pieces of the management of that patient's care to myself and to nurses, where we would actually be seeing the patients on a regular basis, making evaluations about their treatment, their laboratory values, how they were responding to therapy. If there was a problem, we would flag it and refer it back to the physician, saying this needs to be addressed at the physician level. But it was during that period of time when we were really spending a lot of time seeing firsthand and dealing firsthand with patients in terms of how they were responding to their medications. And then from there transitioned into industry from that standpoint to being able to work further upstream, if you will, in terms of how new drugs are developed and how they come to market.
Okay. And in that second 10 years that you're describing, the home health care business that you had, especially dealing with, if I understood things right, rehabilitating people who have substance control or substance abuse issues?
That was part of it. There was also some with chronic medical issues. We did a lot of pain management. We did a lot of terminal care. There were a lot of other aspects of that, but the major focus of what we were doing was long-term care, and particularly as it relates to the geriatric population, then inpatient, outpatient, psychiatric, and then in the home care part, we were doing a lot of home care for terminally ill patients, particularly as it related to the pain management piece and the subtleties of good pain management to provide the highest quality of life that could be provided versus their pain management.
Did that involve laboratory work with blood samples and blood levels
Yes.
Of drugs?
Yes.
And then you said you transitioned into the development of new drugs as part of your career.
Into industry, yes.
Okay. And since, how long did you work in that area? In the new drug development?
New drug development was ongoing since 2001 up until last year.
Okay. And last year what happened?
I took an early retirement and decided there's other things to life besides working to death.
Sure. No. Being a PhD student, I imagine academics hear the phrase publish or perish. Have you published articles before?
Yes.
Will you describe those?
There's about 25 total, 24, 25. I haven't gone back to look at it recently, but there were vast majority of those were peer-reviewed publications that were based upon our research, not only at the University of Alberta, but also at the VA Medical Center in Boise, where we did a lot of the clinical studies and the clinical pharmacology in it. And then there were, I think, 3 or 4 book chapters that we were requested to write chapters and books that summarize the current state of the art as it related to drug metabolism. These were,
I'm sorry, what kind of books were these?
These were textbooks that were, one, for instance, was on that was focused on the effects of smoking on human drug metabolism. We did some interesting work with that at the VA Medical Center in terms of using some drugs we call probes to try to understand, number one, what was the effect of age on drug metabolism, what was the effect of smoking on age and drug metabolism. There were some drug interactions there that were particularly of interest. But those chapters came together to sort of summarize the current state of the art at that time.
Do you participate in any professional associations or on any boards?
Yes.
Let's talk about professional associations first. What are they? What do they require of you?
There are really 3 that are pertinent. The first and probably the longest standing one is the American Society of Consultant Pharmacists, and I have fellowship status with that organization. And they are specifically a group that looks, their special interest or their particular interest is in the age-related changes in drug metabolism and in age-related issues of drug therapy management, drug therapy monitoring. And that organization, you can't just pay your money and keep renewing. You're invited in based upon the standards of your training, your practice, your achievements in research, and the ongoing training and education in that particular area. And every 5 years you have to recertify. So you don't join just once. You have to keep recertifying each time. And I've been a member of that group since late 70s when I first joined, and I'm on their editorial board now for their publications.
Let me ask you briefly, what does recertification entail?
You have to demonstrate ongoing excellence in some clinical discipline. In other words, you have to be able to demonstrate that you are actively involved in some aspect of the sort of the charter, if you will, for the organization. And in that particular case, it's age-related changes in drug metabolism.
So you have to keep going in an area that's relevant to that association.
Exactly. And then you also have to demonstrate a higher level of ongoing continuing education than is necessary for most states in terms of pharmacy relicensure. And you get scored in these different, there's other categories as well, community service and other things. but you get scored in these categories, and you have to hit a certain minimum threshold to recertify.
So if I understand right, and correct me if this is an unfair characterization, but you can be licensed to practice pharmacy, and there's your average pharmacist, but to be a member of this association, you have to be doing a lot more than that.
Yes.
When you said that you sat on an editorial board for their publication, what does that involve?
Well, periodically I get asked to review, be part of a peer review process for articles that are written by practitioners or by researchers that want to have their information, their findings published in that document or in that publication. And so it's a matter of not only being familiar with the area that they're writing in, but you also have to be able to sit down and evaluate not only everything from is the grammar correct, which is a minor detail most times, but is their way they develop their concept appropriate? Is the research done appropriately? Are the statistics done appropriately? Did they use the right citations when they cited what they were basing their work on? And sometimes it's an awful lot of work. It takes a lot of time to do that. And I've cut it back to just that particular publication, ASCP, because it does take a lot of time. And I was at one time on 3 different editorial boards, and it was just too much. And so you had to just cut it back. But this one, when you get the articles, you have to spend a lot of time. I mean, you're basically starting from square one, trying to understand their concept, their methods, their materials, how they did their work, was it done ethically and appropriately, and are their findings well-based? And this is one of the biggest things in the science piece is, did they come to the right conclusions based upon what they put in their paper or how they went about it?
So as an editor, you said grammar's part of it, but that's just the smallest part. Really what you're doing is, in order to keep our publication respectable, we have to make sure that the articles that are published through it are good science.
Yes.
Is that correct?
Yes.
What other associations do you participate in, or are you a member of?
The other major organization that I belong to is the American Society of Clinical Pharmacology and Therapeutics, and that is also by invitation. You have to be nominated to be placed into that organization. It doesn't require the recertification that's required by the ASCP, but the bar for getting into that organization is pretty high. You have to be able to demonstrate much the same kinds of activities, not only from the clinical standpoint, but from the research standpoint, from the training standpoint, from the ongoing commitment to patient care and improvement in how patient care is provided, either through research or through innovative, new, and unique approaches to patient care. So that organization is probably one of the top 3 or 4 in terms of clinical pharmacology, and they're specifically looking at new drug development, the new frontiers in terms of where drug development, drug therapy, the future of right now it's pharmacogenomics. It's the understanding of how genetics affect the way we metabolize drugs.
So similar to a peer-reviewed journal, it sounds like this association is kind of an elite, I don't want to put a negative spin on it, but an elite club that you're nominated to if the other members of the club say, look, his work, his research, his experience passes muster.
Yes.
Are there any others?
The final one is probably the most important one for discussion at this point is the Society of Forensic Toxicology, and I was nominated. You have to be nominated by current members, and you have to go through a fairly extensive nomination process, and your nomination has to be supported not only be brought up by one member, but you have to have written recommendations from 2 people within the organization who are familiar with your work to get in front of the panel that reviews this information. And it requires one of the principal requirements is that the focus of your current work has to be in the area of forensic toxicology. You don't have to be a certified forensic toxicologist, but you have to be practicing or working in that area. And that organization is I've been to a number of their meetings, and they're a very high-level organization in terms of understanding and developing an understanding of forensic toxicology as it evolves, as we get better with instrumentation, as we get better understanding the pharmacology, as we get new drugs. There's a lot of happenings within the industry that, or within the discipline, I should say, that are important to keep track of, and that Society of Forensic Toxicology does that.
Membership in that society, does that require you to keep up to date on how things are developing?
Yes.
You said that might be, that association or that society might be the ones most pertinent to our discussion today. Can I ask you to define or to describe what forensic toxicology is?
Well, toxicology is a discipline within the area of pharmacology, and toxicology specifically addresses the issue of the adverse effects of drugs on the body.
That's where the word toxic is built in, is that correct?
Right, yes.
So we're talking about drugs have beneficial effects, but they also have maybe toxic or bad effects.
Yes.
And toxicology is the study of those adverse effects, is that
Yes.
right? Okay.
And the forensic piece is usually related to or surrounding events that cause either very severe or even morbid side effects or mortality, in the sense of looking at things after death or what may have caused the death as it relates to drugs or chemicals in the human body.
Okay. So we're studying the adverse effects of drugs in relation to death.
In some cases, yes.
Okay. Okay, thank you. Have you testified in death cases before?
Yes.
Have you testified as an expert?
Yes.
Would you have an estimate about how many times?
In just specifically death-related cases, a dozen or so.
How about when it comes to cases involving your opinion about forensic toxicology?
In the broadest sense or broadest definition of the term toxicology has been well over 100 times.
When it comes to the cases involving death, what kinds of cases were those?
In some cases, probably the majority of those cases were drug or alcohol-related fatalities, in which there were questions about the level of impairment in the person based upon the analysis. Also looking at some of any medical issues that may have been surrounding or involved in that case at that time. There's been others that were murder cases in which there may be an issue about the level of impairment or the drug involvement, either in the accused or in terms of the decedent. There's a few unattended deaths that were probably mostly drug-related. The unattended deaths found days or weeks later.
Nobody else was witness to what happened?
And there was absolutely no witnesses, no nothing. All we had was the decedent. And then there's been a few cases that involved the issues surrounding self-inflicted suicides and/or in custody deaths that I've testified in terms of the effects of the working with the coroner's office, a medical examiner, in terms of trying to understand what was going on in terms of not only the medical issues but the pharmacological issues that were associated with that individual's either medical treatment or lack thereof at the time.
Okay, so what role did the drugs play in some of these deaths? Is that
Exactly.
what you're opine about?
Yes.
How is that process done? How do you form that opinion and analysis when you're asked to do that?
Well, it usually starts with and the kind of the simplest set starts with the toxicology report. What did you find at the time of the autopsy in that case? In the situations where, pardon?
I'm sorry, can I back you up a little bit? Where does that toxicology report come from?
It can come from two sources. It can come from if the individual is being treated medically at the time of their death. There's usually some laboratory reports that are surround that period of time when they're in the hospital. But more often than not, the forensic, the important one, is what we get when there is an autopsy that's done and samples are taken at that time for forensic analysis.
When you say samples are taken, what samples of what?
Just about everything. It could be blood, it could be urine, it can be tissues, it could be vitreous humor, it can be cerebral spinal fluid, it can be virtually anything where a drug might be found. They don't always analyze all of it, but they usually start with analyzing the blood and or urine is the first place, and then it can branch out from there depending upon what was found.
Okay. Will you describe briefly, I know there's a lot of complicated science involved, but if you can give us a brief overview, when a blood sample is taken, how is the toxicology report generated?
Well, if the blood sample, if it's taken, let's start with the case with a decedent. If the blood sample is taken, it's going to depend on the proximity of the sampling to the time of death. In other words, if it's very proximate to the time of death, blood samples are relatively easy to get, depending if there's an absence of trauma. So the blood sample preferably would be taken from a femoral vein. There's appropriate ways to collect that sample. There has to be certain steps that are done to make it appropriate. It can be taken from the portal vein. It can be taken from, which is the liver. It can be.
And when you say femoral vein, femoral refers to what?
The femoral vein is in the legs, usually from basically the waist down.
Is it near the femur? Is that why it's called femoral? Or?
Well, no, it's just it's on the inside of the leg. There's femoral vein and femoral artery that supply, the artery supplies blood to the lower extremities. The femoral vein brings it back. That is probably the most common site of collection if it's available, but there's other places it can be collected as well. And then there's a chain of custody if usually there's a chain of custody that's established and it's sent off to a reference lab for testing.
Okay, and I didn't mean to interrupt you. You were talking about the portal vein coming out of the liver. What are some other sites where blood is drawn?
It depends. They can be taken from the heart. Can be taken from. It just depends on where they can access it. And the standard years ago was to take it basically from the cardiac blood, cardiac site.
How many years ago are you talking?
That was probably up until the mid-2000s. Okay. And then there was kind of a shift in wishing to have it only come from the femoral vein when it's possible. There are times when, if it's an extended period of time after death, days or maybe even weeks, sometimes there isn't blood to get. There's fluid that you get, and it's a compromised situation to start with. I don't want to go into the details there.
We're getting into an area that might be kind of gross, but when you're talking about there's no blood, there's just fluid, why is that? Well,
it's a process of putrefaction. Bacteria break the body down and it begins to dissolve.
Okay, so we're talking about rotting?
Yes.
Okay. When you said a chain of custody is established, the blood sample is sent off to a laboratory, what do you receive out of the laboratory?
Laboratory will send back a report that will show their, it usually is broken into two pieces. One is an initial screen, which is a high throughput screen to see what was there, and then a second part of the report that will say, okay, this is what we identified in the initial screen. In other words, we got this drug, and this drug that showed positive. Now we're going to do, there's a process called gas chromatography, mass spectroscopy. There's also a process called liquid chromatography, mass spectroscopy. And I don't want to get out in the weeds on those two, but to suffice it to say, the reason for doing those is to verify that what we saw on the initial screen was there and to quantitate it so we know exactly how much is there. And that's the report you get back, and it'll show you the initial screen. It'll show you what was the validation or the verification in terms of the steps that they did to do that, and the quantity that was present, and then usually a description of what those numbers mean in broad terms.
Your Honor, may I approach?
You may.
Dr. Dawson, I'm showing you what's been marked as State's Exhibit number 33. When you look at that, are you able to tell what it is?
Yes, this is the toxicology report from the medical examiner.
Okay. And at the top part there, you've mentioned the screens just to determine which drugs are positive or negative, which drugs are present or not present. Is that the top table there?
Yes.
And then down below, there's another table titled quantitative.
Yes.
Is that the number amount that you're talking about through these different ways of measuring what levels or how much of a drug is in the blood?
Was in the sample at that time, yes.
When you, well, let me ask generally, just to make sure, what's the purpose of analyzing blood samples removed from a dead person? What's your objective?
Well, primarily is to try to understand if drugs played a role or what role the drugs might have played in that person's death, and also to try to understand something about the burden or the load, if you will, in terms of how much that drug was there, but also in terms of sometimes at the time this sample is taken, we don't have all the information. Sometimes we do, but we don't have all the information of the investigation surrounding the circumstances of the death. So this will help us look at, yes, there were drugs involved, or no, there weren't drugs involved at this time, and it's particularly important in unattended deaths. But it's part of the discipline. It's part of looking at trying to understand why somebody died.
Okay. I think we've covered this already, but have you analyzed postmortem blood samples in your work before?
Yes.
Can you describe the process that you go through in performing this analysis?
Well, a lot of it depends upon the preceding circumstances. And one of the things that we have to keep in mind is that this phenomenon of postmortem redistribution. We can discuss that in greater detail, but the important thing is that we begin to look at, number one, okay, I have this drug present in the blood sample. Did that person have access to that legitimately, or was this an illicit substance? And that kind of directs us into a different area. But to begin to look at next is, what was the time of the sample when it was drawn relative to what we know about the time of death? And then where was the site within the body that sample was collected from? And then what do we know about the physical chemical characteristics of those drugs in terms of, number one, how they're administered, number two, how they're metabolized, number three, what happens with them over a period of time. There are drugs that just sitting in blood break down with no metabolism or anything. None of these drugs in this particular circumstance fit that, but those are some of the things that you have to understand when you're looking at a particular drug in a blood sample, when you're looking at that postmortem analysis. There's also the piece with sometimes if there are metabolites present that have as much or more pharmacology associated with them than the parent compound. So it's kind of a multifaceted approach that you look at and begin to try to piece together, what was the most likely circumstance or what is likely to have been occurring at that time. And it's sometimes very difficult, depending on the circumstances, to try to come to a very clear picture, but still you can get a picture of the circumstances at that time.
So you're saying there are a variety of variables that need to be considered and factored into your conclusions?
Yes.
I'd like to talk about some of those. First of all, when it comes to the person that the blood is taken from, what are some of the factors that you consider relative to the person whose body this sample came from?
Well, I'm not sure that this isn't in any particular order, but one of the things is the time interval from the time of death to the time the sample is taken.
Why is that important?
Well, the interval has to do with it depends on what drug you're looking at in terms of if there is a chance that there could be bacterial degradation of that drug, or converting or producing things like alcohol can be erroneously elevated in after death, depending upon the level of bacterial activity in the body. And the time interval becomes very important. The other piece of that is it's very important to know what the storage conditions of that body was from the time of death until the time of autopsy. And it's important to know if that, in cases where you have somebody who may have been exposed to the elements for days versus being transported to the coroner's office or medical examiner's office and placed in refrigeration in a very short period of time, because that affects how drugs are preserved in the body as well.
You've talked about metabolism a bit. Is metabolism a function of life?
Generally, yes.
So if I take in a drug as a living person, and depending on that drug and the health of my body or the condition of my body, the drug will be processed and eventually excreted through that process of metabolism. Is that a fair generalization?
That's in the broad strokes, yes.
Okay. When somebody dies, does that same process continue?
For a short period of time.
How short?
Well, that depends on it depends on a variety of things. It depends on the drug. It depends on a number of things. As a general rule, we don't expect to see the same rate. That rate is going to reduce because dramatically in a very short period of time for most drugs, because it's not being circulated. There's no blood circulating through the liver. The liver is the primary site of drug metabolism. Some drugs are not metabolized there, but it's fairly rare. I'm going to go use the example of cocaine. Cocaine continues to break down and its metabolites form just being in the blood, even when it's stored in refrigeration. So that's a little bit of an issue when you try to study that one. But that's an outlier. That's kind of an exception to the general rule. So you end up with circumstances where, yes, metabolism could occur for a period of time, but generally, when the blood isn't circulating, metabolism, for all intents and purposes, is not an ongoing process.
And that kind of cuts my next question. Does the movement or the transfer of substances in the body stop just because someone's died?
Not exactly. If I understand your question correctly, is do things stop moving? Do they freeze in place?
Right.
No, there's a phenomenon. This known as there's something called Fick's law, F-I-C-K-S. And it's about equilibrium. And if you have a high concentration of a drug on one place and a low concentration in another place, and there's a semi-permeable membrane, such as a vessel wall or some tissue between them, Fick's law says this high concentration wants to go over to where the low concentration is. It wants to be equal on both sides. And this is a function of it's a function of the difference in the concentrations. We see this in a variety of circumstances, but it's most important with, for instance, with drugs passing from the blood to the tissues or vice versa.
Similar to wind and high pressure wanting to go blow
To the low,
to a place where there's
yes.
low pressure. Okay. If there's that a higher concentration on one side of the memory than on the other, what would keep it there?
If the fluid that it was in was frozen,
Let me ask in a living person, what would keep it there?
well, in that circumstance, there has to be an active process that makes it go there. For some reason, there has to be some physical, chemical process that builds that up, and it has to do with, for instance, if that where that high concentration is in fat, it's because that drug is more lipophilic. In other words, it dissolves more quickly in fat than it does in water. And so when
Lipophilic means it likes to be with the fat.
yeah, exactly. And so you have circumstances where as the drug goes out, it sort of gets sequestered. That's kind of a bad word these days in politics, I guess, sequestration. But anyway, it's one of those things where it sort of gets sequestered there. It doesn't want to go back. And the concentration can build up and build up and build up, and there'll be a big differential between the two. That's not really an active process in the sense of some enzyme in that barrier picking up this molecule and putting it over there and picking up another one, putting it over there and make it stay there. It's that perfusion, it's that equilibrium, but it goes there but it doesn't want to come back. It stays on that side of the membrane.
Okay. You talked about enzymes picking up molecules and moving them across membranes. Is that a function of life usually?
Yes, classic example of that is like with the transport of sodium and potassium across cell membranes. There's an active process that keeps potassium inside of cells and sodium outside of cells. It's how our bodies work. I mean, it's one of the ways, but it's how electricity is conducted and how nerves function and a variety of activities within the body.
So when our bodies die and those processes cease, what happens, for example, to the sodium and the potassium?
Well, there's nothing to keep them where they were, and so the equilibrium, there's nothing to keep moving it back and forth, and so they will eventually, they will start to seek their equilibrium.
So if you take a blood sample from me while I'm alive, it'll have a lower level of potassium. After I'm dead, my cells start to release that. You'll find more potassium in my blood. Is that correct?
That's possible, yes.
When it comes to we've kind of gone down a path of talking about some of these issues, and I'd like to continue talking about them. But first, when it comes to the characteristics of the person that the blood sample is taken from, what are some of the factors that you consider when it comes to whose body did this come from? You've mentioned the time interval between when they died, when the blood was taken. What are some of the others?
Well, certainly there's, the basics. We look at sex, we look at general body build, we look at age, we look at pre-existing medical conditions. Each one of those plays its own particular major or minor role depending upon the drug that we may be looking at. We know that certainly from the standpoint of age, there are age-related changes in metabolism that usually begin to occur in the 60s to early 70s. I mean, sometimes it occurs before that, but it's a generally, with that, there's not a golden rule that says at 58 you only have this amount of metabolism left. Everybody's a little bit different based upon their history and their exposure. And so, but that medical history begins to tie in there. If we know somebody was an alcoholic, that raises some real questions about how well their liver may be functioning or their kidneys may be functioning. If somebody was a diabetic, raises issue about their kidney function. So that's where that medical piece begins. And so all those pieces begin to be pulled together to try to understand what am I seeing in this particular blood sample? How is there something there that will explain to me or at least shed some light on why I'm seeing what I'm seeing? and then going,
When you say why you're seeing what you're seeing, you're talking about the numbers in your toxicology report generally.
well, they don't always explain the numbers, but what it does is it begins to put some context around those numbers. A lab value is just a lab value until you can put some context around it.
Okay. When you talked about medical history, you talked about someone being alcoholic or diabetic and how that will function, or how that will affect the function of different organs. I'd like to ask you about the drug-naive patient. Is that part of the medical history that you consider?
That's part of that medical history that's as much as can be understood is important, yes.
Will you tell us what a drug-naive patient would be?
Well, it's probably best explained by example, and that would be when somebody is given a central nervous system depressant drug for the very first time, whether that's Tylenol number 3 or whether that's a codeine cough syrup or whatever the case. The very first time, the effects are more likely to be more exaggerated, if you will, or certainly more sensitive to the effects or the side effects of that drug than they would be if they've taken it for a long period of time. So if you take an individual who is naive or hasn't taken that medication before, this, like I say, this is particularly important to central nervous system acting drugs. Same thing with stimulants, but certainly with CNS depressants or painkillers, the mantra is to start low and go slow because of this very, very important effect.
Okay, so how does that contrast with someone who's a drug experienced?
Well, you get it at different levels. If you have, probably one of the best examples is the case with individuals who are addicted to narcotics, where as they become more and more, their brain actually undergoes, their receptors undergo changes that causes them to require more and more drug to avoid the feeling of either lack of effect or withdrawal effect. If a heroin addict, for instance, suddenly their heroin is taken away from them, they go into very profound withdrawal that can even be life-threatening. And this is because the receptor physiology, pharmacology has changed dramatically.
And can you explain that a little bit? When you talk about receptor physiology, what are you referring to?
Well, the actual number of receptors change.
Are we talking about in the central nervous system?
In the brain, yes. And so when you have people with chronic pain patients are one of our biggest nightmares from a patient management standpoint, is that there is a huge psychological component to their pain, but also in terms of their tolerance to the medication. If you take a medication ongoing for a period of time, you begin to require more and more to get the same pain relief. And these patients usually present in a circumstance where you almost have to take them back to zero to get them under control because their narcotic management is so far out of control.
So if I'm using a lot of narcotics, you're saying I need to get more and more of the drug in order to keep the same effect because my body is building up a tolerance to it?
Yes.
Would I be able to take more of a narcotic than someone who had never taken one before and be okay?
If you were habituated?
Yeah, if I was habituated, I'd been taking the drug for a long time, maybe I'm even addicted, and the next person comes along, they've never taken the drug before at all. Am I going to be able to take higher doses than they will?
Yes, the doses that you would be taking could very well be fatal to somebody who had never taken it before.
So if someone is using high amounts, then they go through the withdrawals, and they kind of reacclimate. You've said you kind of walk them back to zero. And then all of a sudden the next day they go right back up to the doses they were using before when they had issues or they were addicted or whatever. They had their tolerance. What will that do to them?
They're at risk for death.
Okay. Could someone become an experienced drug user within a week?
That's not been my experience.
Is it possible?
it would depend upon a number of circumstances, particularly relating to the drugs that were involved in the medical condition that was being treated.
Maybe when we get to the specifics of this report, we'll come back
Yeah.
to that question. Now, when it comes to drug tolerance, age, weight, all of these, medical history, all of these other things, why do you have to account for those?
Well, age has a bearing because, as I've indicated, that older patients just don't metabolize drugs very well. Sometimes very young patients don't metabolize very well. Body weight could be very important in a morbidly obese patient. We're not talking about someone who's 20 pounds overweight. We're talking about somebody who is 150 pounds overweight, where you have this huge change in their volume of distribution, where things can go in their body. But that,
You're talking about volume of distribution, you're talking about when things are pushed on the other side of the membrane.
yeah, how big that bucket is.
So if you have a drug that likes, for example, fatty tissue, if someone's morbidly obese, they have more fatty tissue to keep that drug around. Is that correct?
Yes.
What you're saying?
Yes. Okay. And then the previous exposure to drugs or drug therapy, particularly as it relates to drugs that can be toxic to the liver. Alcohol is a classic example. There are other medications that can compromise liver function, but in the average circumstance, there's not really a good barometer to say these are the liver functions tests unless they're really out of line, unless they're really abnormal. There's not a real good yardstick to say at this point we're going to cut the dose 50%. There is in some cases. There's a thing called a Child-Pugh score that we use in patients who are in advanced stages of liver disease and liver cirrhosis and that sort of thing, but it's very complicated that we would look at. And these are patients that are well known to you usually when you see them.
You know that they have liver issues.
They have liver issues because of some other clinical signs and symptoms that are associated with that.
Okay. So all of these factors weigh on your mind as you're looking at those numbers on the toxicology report and trying to figure out what do they mean?
Yes.
Is that correct?
Yes.
Okay. Can I have just 1 minute, Your Honor?
You may.
When it comes to all the factors involved with a person, age, weight, medical history, these things we've been discussing, when you're going to form an opinion, you said earlier that sometimes you get that report and the investigation's not totally complete. Maybe some of those pieces of data are missing. Does that preclude you? Do you need every last detail about a person in order to arrive at some general conclusions?
Not necessarily, no.
Why is that?
Well, it's unusual if we have every single bit and piece of information you would like to have. But there are certain common threads that you can pull through and to look at the toxicology report and begin to formulate a concept that, well, okay, I need to rule out this piece as playing a role. It's what we call a rule out mode or rule out hypothesis. Sometimes we can't point to it and say, that is that, but I can go, well, I can't get there from there, but I can go around and say, I know it's not that, I know it's not that, I'm pretty sure it's not that, it's not all these others, and I'm getting down to, it's like any other investigation. Sometimes you don't have if the answer was that obvious, we wouldn't have to be doing all these things, but it's about looking at, this is what I have, now what other things can I rule out as having participated in that?
What, that method, what's that based on? What assumptions are that based on?
Well, it's a diagnostic, it's a process used in medicine.
Maybe I can clarify. When you talk about ruling things out, let me rephrase my question. When you have a lack of certain data about an individual that you're analyzing, or whose toxicology report you're analyzing, what assumption do you start from about that person? Do you start from the assumption
That they're average.
Okay. And can you describe that?
Well, it's the quintessential 170-pound, 5'10" white male that you assume is sort of average in terms of their distribution of how they live and breathe, and they're not abnormal in any particular way. They're not missing kidneys. They're not those sorts of thing. I mean, you start with a basic assumption until then. Okay, this wasn't a male. This was a female. Okay, this wasn't a 45-year-old male. This was something other. And so you start factoring. Okay, that's not really important to this discussion, but this is. So you start making, in my mind, in my training and experience, and that's how you begin to make a learned approach to trying to understand.
What statistical model is that average person based on?
It's what they call a Gaussian distribution, and it's a statistical thing about the human population as a whole. When you look at some particular function, we all fit within that bell curve.
Some people are over here, some people are over here, but on average, everyone's
close to 70% are in that middle piece somewhere.
So you kind of take that average patient as a starting point, and then you use the factors that you do have information on about the person that you're analyzing, and determine which factors might bear on your conclusions.
Yes.
Is that fair to say? Let's talk about the factors you consider when it comes to the drugs that are reported in the toxicology report. What are issues that will affect your analysis based on which drugs are there?
Well, a couple of things come to mind. One is in terms of, was there some, number one, was what was done in the original screen, were those drugs verified on subsequent analysis? Because there's things that can interfere with that initial screen. And so you look at the reliability of the analysis. There's, if you have GC mass spec or gas chromatography mass spectroscopy confirmation, that's what it's called, confirmation of what's present and how much is there, then you can put that in one bucket and then move on to the next piece. And the next piece is the source of the sample. Then, because if it's urine, that puts it into a different spin in terms of what do those quantities mean versus if it's in blood. Then where was that blood sample obtained? And that puts a little bit different spin if it's femoral versus cardiac. And from just that toxicology report piece, that sort of sets up, it isn't the final action, but it's a piece that begins to set up, well, let's see, I need to look at some other things to try to understand, to get a perspective in terms of what's going on with those levels.
All right, let's talk about specifically where blood is drawn from. You talked about the heart versus the femoral vein, or the cardiac blood versus the peripheral blood. Are those fairly synonymous?
Yes.
We've talked already about volume of distribution, where the body will push a drug into cells at, depending on which drug it is, at different concentrations. Is that a fair?
I'm going to correct you on one point, and that is that the body most times does not push it in a direction, but rather there is a physical chemical properties of the drug that attract that drug into those tissues more so than it might someplace than say in the blood. It's an oversimplification, and don't lose me here, but the blood is basically aqueous.
I'm sorry.
Water. I mean, there's a lot of water there. In the tissues, there's less so, but in the fat, there's even less. And so every drug has a different solubility. Have you ever...
The level it dissolves.
The concentration or the amount will dissolve in something. And this is why they have things like isopropyl alcohol to dissolve the gummy stuff off the back of something you bought that you're trying to get the sticker off of, because the sticker stuff doesn't dissolve in water. I mean, that's as simple as I can make that.
It won't work, but something else would.
Something else will. And so there are some drugs that go into that fat, and that's where they stay. They don't come back, or very slowly come back.
Okay. Can you describe or define for us what cellular lysis means?
Cell is a cell, and lysis means the cell is disrupted. It breaks up, opens up, and spills its contents.
How does death affect cellular lysis?
Well, it accelerates that process because there are certain products of cellular metabolism that have to be removed and have to be processed and taken out of the cell in a somewhat orderly fashion. If those are no longer being taken out, the chemical characteristics of the inside of the cell change and the cell is destroyed.
And when a cell is destroyed, and if there is a drug that's been distributed to that cell, what happens when the cell is destroyed? What happens to the drug?
All the contents leak out and go wherever they're able to go to.
We've talked a little bit about postmortem redistribution. What does that mean? Postmortem?
The postmortem piece is self-explanatory. Is the after death in tissues of the body are no longer being perfused, and if there is some difference between
Can you describe what that is?
okay, the blood is no longer circulating. There's no longer a sort of this attempt at equilibrium that's taking place. We call it homeostasis within the body. Things stop.
The exchange of things.
The orderly exchange is disrupted. And so now you have drugs that might be, say for instance, a drug might be in higher concentration in a particular tissue. Say for instance, lung tissue, then it might be something, it sequesters there. Well, without the circulation to keep that process orderly, if you will, then this Fick's law comes back into play and things start to seek their equilibrium. In other words, drugs start moving around. You get a higher concentration over here. It wants to move back to lower concentration. It'll do slowly. And each drug does it at a slightly different rate and to a slightly different extent. But basically that postmortem redistribution is something that is not really well understood in many respects, but it is recognized. And there's a great deal of debate about how significant it is given certain circumstances. The problem is we can't study it very well because it's not really ethical to do some of the things that would need to be done, and we just don't have, it's almost all case studies or anecdotal reports.
I'd like to come back to that for a minute. I just want to make sure I understand what you're saying about this redistribution. So during life, during normal cellular perfusion, this exchange to kind of keep some drugs on one side and that interaction between the membranes, when somebody dies, if there's a higher concentration of the drug in the tissue, and that drug it wasn't very soluble in water or didn't like the blood very much, after death, it tends to leach, or it can, depending on the drug, it can leach back into the blood.
Generally, yes.
Okay, and how would that affect what's reported on the toxicology report?
Well, it depends. It depends. Usually what we see is if postmortem redistribution is occurring, we will see, if we were able to take samples sequentially, we would see a gradual increase in the amount of drug that was present in the blood, depending upon where the sample is taken. And the difference or the amount that comes back is dependent upon the physical chemical characteristics of the drug, its volume of distribution, the storage conditions from the time of death, and the probably as much as anything is the physical chemical characteristics of the drug in terms of where it might be sequestered.
You've mentioned it depends on where the blood is drawn from.
Well, if you have different sites within the body, cardiac being one, portal vein being another, the femoral vein being another, our science so far has told us the femoral vein is probably the least likely to occur. If the sample's taken properly, it has to be done a certain way. That it's less likely because there is no way for kind of back diffusion of that drug into that vein, in that section of vein in the leg.
As opposed to blood taken
in the heart, because in the heart, some drugs, if they're sequestered in the lung, there's a big, huge connection between the heart and the lungs, and in terms of the perfusion of the blood there. And so if over a period of time, drugs can back diffuse, if you will, and seek that equilibrium, that concentration can go up in the blood.
If the cells are rupturing and the drug's leaking back out of the cells into the blood, and the drug tends to be in the lungs or somewhere in the central cavity, it's more likely to make its way to the heart than it is down to the leg.
Yes.
So just because it's closer?
Yes.
Okay. So how do you tell whether a drug is being affected by this redistribution out of the cells back into the blood? Let me ask that a different way. How can you tell whether this redistribution from the cells back into the blood affects the report, the number that you receive on your toxicology report?
Well, there's I take an approach from 2 or 3 different angles to try to understand, number one, the drugs that are involved, and look at first of all, at their volume of distribution. The volume of distribution, as I said, it is a reflection of how big the tank is, how big the bucket is the drug is going into. And if it goes a lot out into the tissues, it has what we call a high volume of distribution. In other words, the amount we see in the blood, you would think would be higher given the dose that was given, if we give somebody a dose. And if it's a high volume of distribution, it virtually all leaves the blood. It goes away, it goes into other tissues. So if you have a high volume of distribution drug, then you started out with this high concentration over here, then when circulation stops or at the time of death, over a period of time, that will start to leach back into the blood slowly. Part of that depends upon the physical characteristics of the drug as well. If it's highly lipophilic, as we said earlier, it might be slower. And so that's why that factors into that interval time. Also in terms of not only the volume of distribution, but also in terms of the physical chemical characteristics, in terms of is that, as I said, the lipophilicity or lack thereof of a particular compound, or where it may be specifically sequestered. And if we have something that, if you look at, I'll give the example of cardiac medication, lanoxin, which is a cardiac glycoside, it's really high concentrations in the heart. You can get enormously high postmortem redistribution with that drug if you take a cardiac sample. If you take a femoral sample, less likely so.
So the heart blood, that type of drug, will tell you not necessarily what amount the blood was coursing through the bloodstream, because some of that may have come from the heart tissue itself.
Yes.
But the leg sample will tell you more about the accurate, maybe a little bit more accurate levels about what was coursing through the bloodstream, because it's not affected by the leaching out of the heart since it's so far away from the heart.
It generally is.
Generally, okay. When it comes to a low volume of distribution, does that mean that there's roughly a similar amount in the blood as in the tissue? Or how would you describe that?
Well, it's a mathematically derived concept, and you know there's a certain volume of blood in the body, a person of a certain weight and size. And you give a drug and you look at what we call the area under the curve, the amount of drug that's present in say a blood sample. And there's a formula that it gets plugged into that helps you understand what the volume distribution of that drug is. And a low volume of distribution drug would be somewhere in the 1 to 3 liters per kilogram range, in that area. You get above that and you start getting into what we call high volume of distribution drugs. it's a pharmacokinetic standpoint, and I don't want to get too far out in the weeds with that, but it really helps us to understand, you know, where do these drugs go once they're absorbed into the bloodstream.
Okay. So a low volume of distribution drug effect is less likely to be affected by post-mortem redistribution or leaching out after death.
Generally, yes.
Okay. Given all of these factors, actually, a couple more I'd like to discuss with you. Can you talk about the half-life of a drug?
Half-life is another concept that we use to understand how drugs are metabolized in the body. And the best straightforward example I can give is it has to do with how quickly things are eliminated. And let's take a hypothetical drug that starts with a level of 10 in the body. The units are immaterial for the demonstration, but if we start with a level of 10, and in one half-life there will be 5 left. Another half-life there will be 2.5 left. Another half-life there will be 1.25 left. And don't ask me the other one because I can't divide that quickly, but you kind of get the idea in terms of where that goes. It's the amount of time that takes to remove 50% of the drug that's remaining in the body.
So if a drug has a short half-life, what would you expect to see?
Well, drugs with short half-life are into the minutes or hours, a few hours, and you see a drug that would disappear from the body very quickly. As a general rule, it's not pure straight line, but it's pretty close to straight line.
And by contrast, something with a long half-life is going to be around in the body for longer.
The longer the half-life, the longer it stays in the body, and the longer it takes to reach what we call steady state. In other words, a long half-life drug takes a long time to build up in the body.
And why is that?
Well, it's a phenomenon associated with if you take a drug by mouth and it's absorbed, and if you look at the blood levels, you see it go up and then it comes down unless you add more drug. If you take a drug with a long half-life, the drug stays around longer, but it just gradually continues to increase as you continue to dose that drug because it's not being eliminated as fast as it might be as a short half-life drug. I don't want to get into that in terms of the mathematical piece of that, but it has to do with the rate of absorption and metabolism and elimination before we get to what was called steady state.
Okay, I'm sorry, thank you. Is that another factor that you consider when analyzing a report like this?
That's part of it, yes.
Council, is now a time you might break.
It will be fine now.
Okay, let's take our morning recess. Please keep in mind my admonition to you. Don't discuss any subject of the trial with each other or with anyone else. Don't form or express any opinion about the case. Avoid television, radio, or internet news coverage of the trial, and don't do any research on your own using cell phones, computers, or something else. Do they have something to eat? Should have something to eat in the jury room. Thank you. Court's in recess.
All rise.
You may step down. Thank you. Anything this morning?
Mr. Spencer and I approached real briefly
Yeah.
for a record, but.